This is the lecture on domestic violence. In today's society, anger, aggression, and violence are everywhere. Anger is a normal emotional response to the perception of frustration. It's a threat to one's needs. Aggression is an action or behavior that results in a verbal or physical attack. Aggression is not always inappropriate and is sometimes necessary for self-protection. Aggression by patients occurs most often when the nurse sets limits and the patient feels like they are captive or unable to do the things they want to do. An example of aggression is road rage, when anger actually takes shape and you drive unsafely or potentially place others at risk. Violence is the intentional use of force that results in or has the potential to result in injury to another person. Any change in behavior that is atypical for the patient must be addressed. Initial and ongoing assessment of the patient can reveal problems before they escalate to anger, aggression, or violence. A history of violence is the single best predictor of future violence. It's very important to do a complete assessment and head to health physical. Most of our reactions to stimuli come from previous experiences. Aggression by patients occurs most often in the context of limit setting by the nurse. Patients who are at high risk do not like to have limitations set for them. They like to be in control. Demographic risk factors include age 14 through 24, male, low socioeconomic status, inadequate support system, and prison time. These are predictors of violence that you should be aware of, especially within the environment of a potentially violent situation. You will see anger in healthcare. Examples of patients in anger include vulnerability. Many hospitalized patients feel vulnerable when they're admitted to an acute care setting. Uneasiness. They are under stress due to current conditions or disease process. They feel they have limited choices and the lack of ability to make their own decisions. Anxiety. The feelings of uneasiness cause anxiety with family members and healthcare staff. Anger. If anxiety gets out of control, it can lead to anger. Patients may display a shortness with staff, like yelling. Aggression. If anger is not handled, the patient may feel even more vulnerable and become aggressive. And violence. At the end, the patient has become so angry that they hit the staff or harm the family because they can't handle their feelings. So how can we decrease the risk? With self-assessment, you need to question yourself. How do you feel about different patients and situations? How do you handle stress? Can you ignore different stimuli like insults? Will your ability to handle stress or anger hinder or do good for the situation? And then what is your body language? Are your arms crossed? Are you rolling your eyes? Plan starts with an understanding of your patient's current medical problems, stressors, and past history. You must know and understand your patient to understand their ability to handle stress and their potential for aggressive behavior. What are your plans if something should arise? What are you going to do? What does the agency protocol state? An example is a violent behavior in the ER. Are you going to use restraints? Are you going to call security? And then listen to the patient and family concerns. The patient needs reassurance that people are interested and willing to help. This demonstrates a willingness to do good for the patient and shows empathy. Communication. Give the patient your expectations for the unit and personal, like, I expect that you will stay in control. If the patient asks for things, will you be able to meet them? Empathy may help decrease the likelihood of aggressive behavior, but be sure you do not become manipulated. And then personal space. You should be at the same level of the patient. Looking down at them is too intimidating. Also stay at least 1 foot farther than the patient can reach with arms or legs. Are you providing patient privacy? Is there enough break between structured time and personal time? An example is many hospitalized patients don't get enough quiet time or time to sleep, and that increases their vulnerability. Also, do you have an escape route? And then you have to complete continual assessment and monitor for increasing tension and situations that may escalate. It's important for staff to always have an understanding of the environment and how the current patients fit in this environment. With overcrowding, patients have a tendency to rally the crowd and make things worse. It may be necessary to break up the small cliques, which may in itself cause anger. And are there enough staff present? Having less staff present may be easier for patients to think that they can act up and control the environment. Also, are staff aware of and using de-escalation techniques? These are de-escalation techniques. Respond as early as possible. When anger is escalating, a patient's ability to process decreases. Speak to the patient slowly and in short sentences using a low and calm voice. Use open-ended questions, and be sure you are aware of your body language. If psychosocial interventions do not work, there are times when staff have to take further actions. It's the RN's responsibility to assess for the appropriateness of the PRN medication. Oral medications should be given first, as ion injections can traumatize the patient. Seclusion definition is the involuntary confinement of a patient alone in a room or area from which the patient is physically prevented from leaving. It's not punitive. The goal is safety of the patient and others. Restraint definition is any manual method, physical or mechanical device, material, or equipment that immobilizes or reduces the ability of a patient to move their arms, legs, body, or head freely. They should only be used as a last resort and for a short time frame, only until the patient is no longer a risk to themselves or others. Must be directly observed and frequently assessed. And you should always see the guidelines at your facilities, and there are also guidelines in your textbook. Once a patient is settled down, it's reasonable to discuss expected behaviors and consequences if these expectations are not met. An example is a PRN medication, time alone, and the isolation room. With staff and personal safety, avoid wearing dangling earrings, necklaces, and scarves. Ensure there's enough staff for backup. Know the unit and how it's laid out. Know where you can go for safety. Know where the code green button is to call for help. Always have an escape route if in a confined room, and avoid confrontation. It's in the RN's responsibility to assess for the appropriateness of the PRN medication. I'm sorry, I talked about that already. Hold on. Here we go. An example of common drugs used in acute management for violent behaviors are listed here, and you're not expected to know all of these, but they will come up with the patients that you're caring for, so you'll need to know them at that time. Alright, now let's go on to domestic abuse. Some videos to review: Monsters in the Closet, Domestic Violence from a Child's Perspective, and What Would You Do? Help a battered woman or not? Here's some facts. Abuse occurs in families of all socioeconomical, religious, cultural, and educational backgrounds. 25% of all cases occur with intimate partners who are not married. Violence is the abuser's pattern of behavior. Abuse gets worse when one is leaving, such as divorce. Abuse is a learned behavior, not an uncontrollable reaction. People are abusive because they have acquired the belief that violence and aggression are acceptable and effective responses to real or imagined threats. Battering frequently begins or escalates during pregnancy due to jealousy. The abused woman will not seek out treatment for abuse after delivery, but will seek treatment for her infant. Therefore, pediatric practices are important settings to screen for abuse in mothers, as it may have consequences for the infant. Characteristics are passed down from previous abuse relationships: parent to child, and child to parent. There is social isolation due to family secrets. Alcohol and drug abuse are used as socially acceptable explanations. Witnessing violence between one's parents or caretakers is the strongest risk factor of transmitting violent behavior from one generation to the next. Boys who witness domestic violence are twice as likely to abuse their own partners and children when they become adults. 30 to 60% of perpetrators of intimate partner violence also abuse children in the household. When children are abused, they observe parental abuse and then learn to be protective, afraid, or abusive. Social factors that reinforce violence include wide acceptance of corporal punishment, increasingly violent movies and TV shows, and violent video games, websites, and comic books. Violent themes in music and increasing pornography, which is strongly associated with physical abuse of women. Perpetrators are those who initiate the violence. They often consider their own needs to be more important than anyone else's and look toward others to meet their needs. Often the abuser lacked good role models and was deprived of the opportunity to develop problem-solving skills. Behaviors and characteristics of abusers include jealous and controlling behavior, unrealistic expectations and isolation, blames others for problems and feelings, hypersensitive and cruelty toward people and animals, verbal abuse and rigid sex roles, Jekyll and Hyde personality, past battering and threats of violence, breaking or striking objects, use of force during an argument, and constantly checking on their partner. Vulnerable person is a family member upon whom the abuse is perpetrated. With women, pregnancy may trigger it. The woman wanting to be more independent may also trigger the perpetrator. With children, typically younger than 3, they are perceived as being different because of temperamental traits, congenital abnormalities, or chronic disease. They are different from the parent's fantasy of what the child should be like, or they may be a product of an unwanted pregnancy. Older adults, mostly female, Caucasian, and over 75 years old, and typically if they're living with a relative and experiencing a physical and or mental impairment, and can be anyone in a crisis situation. The cycle of violence includes tension building, then battering, then the honeymoon phase. Typically, the victim will return an average of 7 times before leaving for good. So in turn, it may take them 7 times to hear somebody tell them that there's help before they'll actually do anything. So phase 1 is tension building in the purple. The abuser starts to get angry and abuse may begin. The victim feels the need to keep the abuser calm. The victim feels like they are walking on eggshells. Tension becomes too much and there's a breakdown of communication. Phase 2, abusive incident. The abuser is unpredictable and loses control, highly abusive, and blames the victim. The victim is traumatized, is helpless, and feels trapped. And then phase 3, the honeymoon phase. The abuser may apologize for the abuse, may promise it will never happen again, may blame the victim for causing the abuse. They are manipulative and may deny the abuse took place or even say it was not as bad as the victim claims. And the victim has mixed feelings, feels guilty and responsible, considers reconciliation, minimizes abuse, and may believe the abuser is finally over. This power and control diagram is a helpful tool in understanding the overall pattern of abusive and violent behaviors, which are used by a batterer to establish and maintain control over his partner. The abused often are stripped of all ties to society like friends, money, and family, which makes it difficult to leave their abuser. Nurses should be aware of personal emotions and thoughts. Strong negative feelings can cloud your judgment and interfere with objective assessment and intervention. What are your feelings towards victims? Will anger toward the abuser help? Probably not, as the victim will typically defend them. Primary preventions are measures taken to prevent the occurrence of abuse, which include identifying individuals at high risk, providing health teaching, and coordinating supportive services to prevent crisis. All acute care facilities now have to ask all patients if they feel safe in their home. Strategies can include reducing stress, reducing the influence of risk factors, increasing social support, increasing coping skills, increasing self-esteem, and therapy. Secondary prevention is early identification in abuse situations, and it helps to minimize their disabling or long-term effects. Build trust and rapport with the patient before focusing on the details of the violent experience. That is crucial. And then be an advocate. Give them the tools they need so they can leave. You can use the mnemonic RADAR, R-A-D-A-R. R is remember to ask. Framing a question, we are implementing a new policy. The domestic violence rates have increased in our area, and I have made it a practice to ask. A is for ask directly. Are you afraid? Do you feel safe? D is document it in the medical record. A is assess the patient's safety. Is it safe for them to go home? And R is for review options. A safety plan should include important phone numbers, police hotline, friends, local shelter, friend or neighbors to confide in regarding the abuse. They can be instructed to call the police if they hear violence. Practice ways to get out of the house safely. If possible, try to get weapons out of the house. Think about places you could go to escape to safety, and go over safety plans regularly. If leaving the abuser, have a bag ready and hidden. People who would be willing to help can keep the bag. Make plans for your pets. Open a bank account, keep cash available, or open a credit card. Think about how you will escape. An example is while taking out the trash, or walking the dog, or going to the store. Think about how to take the kids safely with you. Have a code word so the entire family knows when to activate the plan. And provide resources within your community for them. These are situations that you are required to report. Refusal to report. The patient may not feel that this is in their best interest, may not be in the best interest for the children, or there can be many reasons for them to refuse. When you do report, you have to notify appropriate individuals and provide appropriate referrals. The effects of abuse include higher incidence of depression and anxiety, suicidal feelings, self-contempt, inability to trust, inability to develop intimate relationships in later life, antisocial behaviors, suicidal ideations, and post-traumatic stress disorder. Recurring symptoms post-trauma include flashbacks, dissociation, poor self-esteem, compulsive or impulsive behaviors like substance abuse, excessive spending and gambling, and multiple somatic complaints. With children, after the age of 5 or 6, they show an indication of identifying with the aggressor and losing respect for the victim. They're at a greater risk for developing behavioral and emotional problems throughout their lives. Adolescents may have failing grades, difficulty forming relationships, increased incidence of theft, arrest, and violent behaviors, seductive or promiscuous behaviors like prostitution, and running away from home. So that concludes part 1 of this lecture.